Hit the subscribe button or visit us at auau.auanet.org.
Good evening, and welcome to AUA's Advances in ADT Part II, a guide for APPs live virtual course. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we can continuously improve our programs. The AUA is accredited by the ACCME and designates this Internet Live activity for a maximum of 1 AMA PRA Category 1 credits. Course handouts from the presentation have been made available to you. Please visit AUA University to access the handouts. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on AUA University immediately following the course. As we at the AUA continue to develop virtual education that meets your needs, we especially welcome your feedback regarding both the content and format following this program. All persons in a position to control the content of an AUA educational activity are required to disclose any relevant financial relationships with any commercial interest. Please visit the AUA University to view Faculty and Education Council disclosures. Coding advice given during presentations are the opinion of the presenters and may not have been vetted through the AUA for accuracy. Please verify accuracy prior to reporting on medical claims. The AUA would like to thank Myovant Sciences Limited and Pfizer Inc. for providing independent educational grant in support of this webinar. Finally, I would like to introduce and extend a special thank you to our course director, Ms. Rachel Hastings, for her time, talent, and expertise in developing this program. Rachel Hastings is a physician assistant working at NYU Langone Health in NYC. She earned her bachelor's degree from Indiana University and physician assistant degree from Rutgers in 2006. She has been working in urology since 2006 and has experience as a first assist in the OR and clinic primarily with urologic oncology. She has worked to build and grow robotic programs at both the academic and community level and is able to provide continuity of care from the office setting to the OR. Rachel is passionate about both patient and practitioner education and enjoys being a part of developing and delivering courses addressing education and efficiency. I will now turn the course over to Ms. Hastings.
Our activity goal tonight, based on the documented need from the AUA Advanced Prostate Cancer Global Needs Assessment, the AUA has created Advances in ADT Part II, a guide for APPs, an educational offering to further update APPs on the latest advancements in androgen deprivation therapy and prostate cancer treatment. At the conclusion of the activity, participants will be able to 1. Recognize the need for a multidisciplinary team to provide care for patients with advanced prostate cancer. 2. Classify stages of advanced prostate cancer based on clinical and radiographic modalities. 3. Apply treatment strategies for different stages of advanced prostate cancer based on current guidelines. 4. Evaluate and manage comorbid conditions for patients with advanced prostate cancer on systemic therapies. 5. Describe the role of genetic testing to guide therapies for patients with advanced prostate cancer. And 6, assess treatment barriers and access to care to therapies for advanced prostate cancer. It is now my pleasure to introduce our 2 subject matter experts joining us this afternoon/evening. Dr. McKay, thanks so much for being here. Dr. McKay is an associate professor of medicine and urology at the University of California, San Diego, associate director of translational sciences, and co-leader of the genitourinary oncology program at the Moores Cancer Center. She is a medical oncologist who specializes in treating people with urogenital cancers. Again, thanks for being here, Dr. McKay. Doris Salazar, nurse practitioner, has been a nurse since 2005, graduated with a BS in nursing and a BA in psychology. She became an adult health NP in 2011, graduating from NYU. She started working in general urology as a nurse practitioner, then transitioned to GU surgical oncology. Obtaining her Doctor of Nursing practice from NYU in 2015, she was promoted to manager within NYU and served as adjunct faculty at NYU College of Nursing. In 2018, Doris transitioned to GU Medical Oncology at the NYU Perlmutter Cancer Center and now remains a full-time NP at NYU in a hybrid role of GU NP clinician and nurse manager while serving as adjunct professor at Adelphi University. Thanks for joining us, Doris. All right. So we are excited to be here tonight as advanced prostate cancer management has undergone tremendous growth over recent years. For decades, ADT with LHRH agonists or antagonists alone was the standard of care for many of our patients. The landscape has now changed dramatically with many randomized controlled trials enhancing our ability to control disease with the addition of many new treatments. These new and evolving treatment paradigms are exciting and lead to an increased importance to stay up to date as APPs have a valuable role in identifying progression, managing disease and treatment-related side effects, as well as being the backbone for multidisciplinary support throughout their cancer journey. Again, thanks to all of you for taking the time out of your evening or afternoon to join us. Today, we're going to work through each disease state, addressing management and treatment considerations, as well as treatment-related side effects. So our first patient is a 62-year-old male, status post-prostatectomy for PT3A Gleason grade 4 disease with high-risk features. His PSA was initially undetectable for 6 months, but now rising. As part of our evaluation, we want to know what his PSA doubling time is. Is it rapid, less than 9 months, or slow? And what his overall PSA is. Dr. McKay, if coming from a urology practice, do you think a rising PSA in this setting should trigger referral to radiation or medical oncology, or okay for us to manage until they've reached these benchmarks of a more rapid doubling time or a PSA of 0.2?
No, I think this definitely triggers a potential referral. You know, this is a high-risk individual. He had T3 disease. He had cribiform and introductal feature. He's a, you know, has several poor risk features and now has a fast PSA doubling time. And so I think he's definitely going to be, you know, thinking about getting staging scans on him to see and confirm that he doesn't have metastases, and then thinking about hormone therapy initiation and even escalating his hormone therapy. And so I think sometimes it's important to have those sort of multidisciplinary discussions, you know, around the rising PSA.
Agree. At my institution, we are primarily using hypersensitive PSA. Do you think there's a value for this with these patients, or is PSA total alone sufficient?
So that's a very good question. I think about the role of hypersensitive PSA. You know, hypersensitive PSA is going to give you readouts to the hundredths or the thousandths decimal place. And while I think some patients really want to get that granularity of kind of having their PSA readout to 0.00 or 0.000, you know, you can get plenty sufficient data with a readout to just one decimal place and get a sense of sort of what their doubling time is going to be. So, you know, if you're dealing with changes that are on the order of 100ths or the thousandths, you know, that's not necessarily somebody who's like needs emergent treatment right now, you know?
Yeah, I think for someone that's very low risk and we're not expecting a rapid rise, they sometimes like that, you know, going out to the 100th or things like that. Whereas someone that's higher risk that you think extra treatment is almost a certainty, that's fine too. As we're trying to incorporate shared decision making and striving towards more personalized medicine, what are your thoughts on early radiation in a higher risk patient versus waiting until that PSA is 0.2? Do you think there's a role for Decipher or looking at pathology, family history, or is it simply in numbers?
Yeah. You know, I think it's looking at the whole multitude of things. You know, I definitely take into account somebody's risk coming in when making the decision around how aggressive to be based off of what their PSA is doing. So if they had an intermediate risk cancer confined to the prostate, and then they're developing a biochemical recurrence, I'm thinking about them a little bit different than somebody who's got a Gleason 9 cancer, Gleason 8 cancer with T3 disease. And so I do think that that's important. The role of Decipher in the BCR setting hasn't been fleshed out as sort of like, what is its utility to guide clinical decision making. I think sometimes we can use that information and just understanding somebody's upfront risk stratification, like they were Decipher high, they have a higher likelihood that they're going to develop metastases and recur despite treatment. Sometimes we may even use just somebody's NGS testing. We know that, if they've got a TP53 alteration, or they've got PTEN loss, or they're BRCA mutated, we know that those are more aggressive behaving tumors, but do they actually impact your decision to say, okay, what do I do for this patient before me? I think a lot of times it's largely based off of what's the absolute number of their PSA, what's the rate of rise of their PSA, what's their incoming risk stratification, and what are the patient's goals? Actually understanding, where does the, what's the patient's level of anxiety around their PSA? What's their level of anxiety around ADT and hormonal therapy? And you may have the same exact clinical scenario with the same risk features in front of one patient with one set of values, and then take that same scenario in front of somebody else who's got a different value framework. They're going to make a different treatment decision. So I think understanding that's going to be really important.
Yeah, for sure. Doris, if this patient is coming in with just this PSA is slowly rising, you're trying to decide on radiation versus continued surveillance and a really low PSA, what else are you thinking about besides this PSA alone?
So at these visits, other than following up with their PSA, we're also evaluating the patient's post-surgical continence level. We are asking them between daytime versus nocturnal continence, which usually comes first. How many pads are they using? Are they using Depends? This is really important, particularly if we're considering potential salvage radiation. If the patient is still leaking, and depending on the severity of the leakage, we may consider referring them to pelvic floor physical therapy. Also, depending on the practice, in the area of practice, we would consider checking A1C lipid panels to optimize them for potential salvage hormonal therapy. That's usually the case in the medical oncology practice.
Okay, so let's say this patient with a rising PSA did go on to get salvage radiation alone. His PSA was rising again with a fast doubling time. Is this a patient you'd follow with PSA imaging or conventional?
I'm more than happy to take that one. I think I definitely would want to get, PSMA PET imaging in this context. That's exactly sort of the context sort of where we're thinking about utilizing it. I would say while there isn't necessarily a need to have to get conventional imaging, if somebody is PSMA PET positive, I do like to know whether they are negative on bone scan or negative on conventional imaging, because I think we're going to think about somebody who's PSMA PET positive but conventional imaging negative a little bit different than somebody who's PSMA PET positive and also conventional imaging positive. And they're going to fall into a little bit different bucket. So I do think until we have sort of restructured our definition of metastatic disease, integrating PSMA PET, we sort of need to do that concordance in the clinic.
Dr. Okay, I would actually ask a follow-up question on this. So in your practice, how do you deal with insurance coverage in terms of getting the PSMA and conventional imaging covered?
I usually have no trouble getting conventional imaging covered. It's usually getting the PSMA PET covered.
Right.
So, I think a lot of times some insurance companies will say, get the conventional imaging first and then let me know. And then there's always, whether there's something that I see on the bone scan, but I'm not sure. So I need to get the conclusive PSMA PET. So I haven't really had a struggle doing it in the order of getting conventional imaging, then, PSMA PET. But now it's all over the NCCN guidelines. You can't turn away from it. So I think if you all are struggling with getting insurance authorization, I would direct people directly to the NCCN guidelines. This is the exact patient population who would benefit from PSMA PET imaging, because it has the opportunity to directly impact clinical decision making. Based off of the results of that test, if it comes back positive, you would change your management plan. You would maybe offer SBRT or escalate their hormone therapy or do other things. And because of that, it hopefully should be covered. I know some insurance carriers, it's a real struggle, but leaning on the NCCN guidelines is generally sort of a good go-to strategy.
I so absolutely agree with that.
All right, so just backing up a second, assuming the imaging with any modality is negative, so this patient is still just biochemical recurrence, our goal here is to prevent metastasis or prolong the time to metastasis. So our management options for this patient is continued surveillance, intermittent ADT, ADT monotherapy, or treatment escalation, as we saw in the PRESTO or EMBARK trials. Dr. McKay, how do you try to decide which is appropriate for this patient? Surveillance, intermittent ADT versus a treatment escalation?
So, I think the decisions around this, I think, are largely dependent on, again, the patient's risk stratification coming in, just at diagnosis, what group did they fit in? What's their absolute number of PSA? What's their PSA doubling time? And that helps me kind of put them into a framework of, okay, what is your risk of developing metastases? Because the reason we treat in the setting of somebody that has BCR without metastases is we want to delay the time to metastases. Metastasis development is a clinically significant endpoint, and it's been shown to be a surrogate of overall survival in metastatic in prostate cancer. So, we ultimately want to prevent that. So if you have somebody whose risk of developing metastases within their lifetime is low, you're gonna slow play their plan forward, maybe repeat their PSA, see how they're doing. If you think that their risk of developing metastases in their lifetime is high, you're going to want to be more aggressive. And so the things that tell me that their risk is high is, okay, what's their risk coming in? What's their PSA now? How fast is their PSA rising now? The other thing about how fast their PSA is rising now, it's really important to make sure you have a couple of points on the curve. You don't want to jump in and say, oh, my PSA was 0.02 and then it went 0.04 and it's doubling in 3 months. And no, your PSA is still 0.04. It's still very low. We don't need to do anything about it quite yet. And when the PSA is so low, sometimes it's hard to get an accurate kind of read on doubling time. And additionally, if somebody is coming off of salvage radiation with hormones and had received maybe short course hormones with their radiation, maybe their PSA is rising as their T is recovering. So it makes it look like the doubling time is faster, but it's really only because their testosterone is rapidly rising. So that could impact things. So I think, thinking about all of those parameters helps me decide, do I just watch? If their PSA doubling time is greater than 10 months, I absolutely do not escalate them with, ENZA or APA from like the PRESTO trial. And then deciding the trigger point, I think a lot of times is dependent also on the patient's values that come in.
Okay, great. So we need to move on to our next disease state here. We're going to talk about metastatic castration-sensitive prostate cancer next. This patient, Mr. Bear, is a 74-year-old who presents to us with a PSA of 24, Gleason grade 5 on biopsy, and imaging reveals metastasis. This is a patient with metastatic castration-sensitive or hormone-naive patient. One key distinction for these patients is they are presenting with high volume or low volume disease. We define high volume via charted as more than 4 bony mets, or the presence of visceral metastasis. So here I put up that there is a difference in the PSMA lesions versus the bone scan lesions. Should we treat this patient as low volume or high volume based on our current guidelines?
I'm more than happy to take this one. So the definition of high and low volume disease is based off of conventional imaging. It's not based off of PSMA PET imaging. It hasn't really been validated in that context. So if somebody's got, 2 sites of metastases on bone scan and that's it, even though they may have more on PSMA PET, technically they're low volume. So, I think it particularly comes into play when you're dealing with somebody, when you're dealing with a situation where somebody's got an intact primary, where there's a benefit to radiation to the primary or surgery to the primary. Most of the data has been around radiation for low volume disease patients. I mean, I would use the bona fide conventional imaging for that, not necessarily PSMA PET.
Yeah, I was going to say many of our tumor board discussions revolve around young, healthy, newly diagnosed, low volume metastatic disease. And is local therapy with surgery or radiation an option for these patients? I think PSMA is changing that a little bit because we're finding more of these patients maybe than we did with conventional.
Yeah. Yeah. I mean, I think it would definitely be, I wouldn't change the management plan around sort of the role of radiation to the primary in that context, but I think it definitely helps with level setting expectations with the patient that, maybe, our goal isn't necessarily curative like we initially once thought, but it's life prolongation, and there's still a role for treating the primary for life prolongation, though it may not necessarily be for cure.
For sure. Speaking of, so low volume, high volume is a key distinction. Some other distinctions in these patients as far as how they present. Can you talk a little bit about your initial evaluation for somebody coming in with this metastatic hormone sensitive or hormone naive prostate cancer?
Absolutely. I mean, I think doing a risk assessment, first, I think completing their staging evaluation, making sure that they're fully staged. Sometimes patients don't have a CT of the chest. They may come with a MR, prostate, and a bone scan, and that's all that they've got. So making sure that they're fully staged, assessing them for symptoms, assessing them for neurologic symptoms, assessing them for urologic symptoms. Some patients who present with an intact primary may have obstructive urinary symptoms. They may need a TURP, assessing them for any, bony pain, pathologic fracture, things like that. So I think is really critically important. I think then that upfront decision making is going to help with deciding on treatment intensification. Are they high volume, low volume? Do they have symptoms? Do they not? Do they have visceral mets? Do they not have visceral mets? Do they have an intact primary or not? So that will help decide, okay, I'm going to give them ADT plus what? Are they going to get, there really is no role for ADT alone in the setting of MHSPC. And there's really no role for ADT docetaxel alone, because we've demonstrated that if you're going to use docetaxel as a backbone, adding an ARSI, whether it be ABI or DARA, improves outcomes. So the decision making to be had is ADT plus X, and what is that X going to be? Is it going to be just an ARSI alone, or is it going to be an ARSI plus chemo? And then is there a role for radiation to the primary? So those are kind of the key decision making. And then I think what's really important, and actually the bulk of the time when people are in clinic, we talk about, and Doris, I'm sure you are doing this a lot in your clinic, is all the whole package of ADT, what that comes with. The bone health, the DEXA scan, the calcium, vitamin D intake. Do they have osteopenia at baseline and need a bone protecting agent? Their cardiovascular health, lipid panel, cholesterol panel, educating around weight gain, hot flashes, treating the hot flashes. If they're on ABI, monitoring the mineralocorticoid with ABI, instructing them around their blood pressure, get a blood pressure cuff, check it every day. So it's all that comes with starting somebody new on ADT. And I think our APPs do an amazing job actually with educating patients, educating family members, and developing good practice models around that full patient care. And for me, I definitely get genetic testing on all of these patients, both on their tumor and hereditary germline testing.
Can we just talk about some of those ADT options as you're looking to kind of start these patients? So very basic, your first, your choices versus Lupron versus relugolix. How do you make that decision? Are there any specific indications for one versus the other?
So very good question. I think the question about LHRH antagonist versus agonist, I think one is, do they need an immediate response? I'm worried about flare in them. I'm worried they're going to obstruct. So generally, I'm leaning towards a GnRH antagonist when I have that worry about their symptoms. And I want to get treatment started kind of quickly. The other thing is thinking about their cardiovascular profile. If I've got somebody before me who I'm really worried about, maybe they've had a prior cardiovascular event, maybe they've got some, you know, arrhythmias, other things like that, where I'm really kind of concerned about just cardiovascular fitness, I'm leaning towards a GnRH antagonist over an agonist. And I think the choice between injections versus pills, I think, is a lot of time patient driven. Some patients prefer to have pills on board. Some patients prefer injections. In the context of MHSPC, where somebody is metastatic and you're not going to be discontinuing therapy, the impetus to put somebody on oral relugolix so that they can have faster T recovery is not really at play here. So I think the role with relugolix here is really more about rapid drop in T, oral over injection, patient preference, and cardiovascular, as opposed to like my T is going to recover faster. So that's sort of how I decide between the different LHRH analogs.
Okay, great. And then just as we're intensifying the treatment, as we're doing ADT plus something else, as we should, are there any kind of, how do you choose between some of those second generations? And then how do you decide who is appropriate for triplet therapy up front versus more of a sequential approach?
I don't, so at the present time, we don't have any data looking at ADT plus an ARSI versus ADT plus an ARSI plus DOSI to really answer the question of what is the contribution of docetaxel to that ADT ARSI backbone. We have the reverse. We have, when you're doing ADT plus docetaxel, adding an ARSI improves outcomes independent of risk group. But we don't have what is more commonly done in the clinic, which is everybody's going to get an ADT plus an ARSI and do I add DOSI. So when I have somebody before me and I'm thinking about the DOSI question, I am looking, do they have visceral mets? Are they really symptomatic? Are they high volume with de novo disease? Those de novo high volume patients do the worst, have the worst survival. And do their genomics, suggest that they may have a more AR independent, phenotype? Do they have like Gleason 10 disease and a very low PSA and they're wildly metastatic? So is there some like discordance between their PSA and burden of disease? So sometimes in those scenarios, I'll lean towards docetaxel.
And with treatment intensification, I feel patients are often concerned about side effects, more meds, more side effects. So I want to just back up a little bit. I know in my practice, when a patient comes in already on ADT and I talk about side effects other than hot flashes, they're like, what are you talking about? I'm sure they were educated on this, but I think, patients, it's overwhelming. They have selective hearing. So Doris, how do you start the conversation of ADT and all these side effects?
So when we're starting a patient in ADT, education is very important. And to Dr. McKay's point, I think we kind of take charge on this. We're usually the ones providing education in more detail and coordinating the patient's plan of care in terms of the education and follow-up. I really can't emphasize enough how important it is to take the time to educate the patient, to educate the family about the mechanism of action, about the potential side effects, and how they can be proactive in monitoring, preventing, and managing these side effects.
And then what are some important aspects of the education process for you?
So I usually start off by explaining how ADT works. And I clarify to them that this is hormonal therapy and not chemotherapy, because a lot of patients have that misconception that they're coming in to start chemotherapy immediately. This tends to ease their anxiety about starting treatment. In very simple terms, I describe to them that prostate cancer feeds off testosterone, and thus by using ADT medications, we are suppressing their testosterone levels to an undetectable level to starve the cancer cells that are then killed with radiation in the definitive treatment setting. In the metastatic setting, I tell them that ADT will put their cancer cells in a dormant, comatose state, and that while incurable, metastatic prostate cancer can be managed with multiple therapies. This helps them appreciate that it is not the medicines that are giving them the side effects, but rather the lack of testosterone This very simple explanation helps our patients understand the rationale for the treatment. Hence, they are more willing to accept it and comply with it. For example, in the definitive treatment setting, where we usually start ADT 2 to 3 months prior to radiation, we may see a PSA decrease and sometimes become undetectable before they start radiation. Some patients may still ask, why do I need radiation if my PSA is undetectable? By educating them in simple everyday terms without the medical jargon, patients are able to acknowledge how the treatment works and have realistic expectations. This is particularly important when educating a patient in the metastatic setting, because we will see their PSA drop and they will become undetectable with new treatments. But as we know, they are not cured, and at some point their PSA will start to rise. By explaining to the patients in the metastatic setting that when their PSA is undetectable, the cancer cells are in a dormant comatose state, but at some point will outsmart the treatment and wake up, patients are less likely to be lost to follow-up when their PSA is undetectable and are more receptive to the treatments when they progress.
I think we need to focus. This is an opportunity to kind of empower patients with education on the ability to be proactive and how to kind of do things for themselves. So as we move into this, how do you introduce the multidisciplinary team that's going to be part of their care?
So before I go into the multidisciplinary team, I do want to touch on the importance of the side effects. To Dr. McKay's point, I tell them that there's going to be a lot of side effects that they may or may not all happen, and that there are things that we can do to manage them. I reassure them that most patients are able to carry on with their routine everyday life work balance while on ADT. And I feel that this puts them at ease in listening to the side effects without an impending doom approach, making them more receptive to learning and feeling in control. That's when I would go into the broad array of potential side effects, testosterone-related side effects, including decreased libido, fatigue, erectile dysfunction, axial weight redistribution with increase in fat and decrease in loss of muscle mass. We discuss estrogenic side effects, including hot flashes, gynecomastia, dry skin, bone density loss that can lead to osteopenia or osteoporosis in the long-term use of ADT. We discuss mood and cognitive changes. And then I emphasize to them and sometimes even scare them a little bit about the adverse metabolic effects, including the increased risk of diabetes and cardiovascular disease if they are not proactive with their health. And this is really where I go into the empowering them, because I tell them that it doesn't need to happen. And we do have this wonderful multidisciplinary team that we work with. So while I reassure them that ADT has all these potential side effects, we can be proactive in preventing some of them by collaborating with the multidisciplinary team. And managing the other side effects with medications if needed. So whenever we're starting a patient in ADT, we obtain a baseline A1C, lipid panel, CBC, comprehensive panel, testosterone, a vitamin D, and a PSA. If their A1C or lipid panel are not normal, or they have a history of diabetes, cardiovascular disease, hypertension, we recommend and coordinate a consultation with cardio-oncology for medical optimization. We have a dedicated team of cardiologists who are part of our cardio-oncology group who will prioritize seeing these patients to optimize their health. We also incorporate other resources such as onco-rehabilitation, which entails referring them to a physiatrist for an evaluation on their activity tolerance and provide physical therapy in the office setting or at home, occupational therapy, and further recommendations to increase their activity. For the patients that are more independent and are already exercising, then I focus a little more education on, weight-bearing exercises, evidently as tolerated and always in a safe manner. Squats, push-ups, even against the wall, and moving.
Multidisciplinary team is so important. We have to get everybody involved, and there's a lot of ways to do that. In the interest of time, we need to move on to our next patient, our next segment. This patient is a 76-year-old male. He had a prostatectomy revealing higher risk disease. His post-op PSA remained detectable at 0.3. He completed radiation and remained on ADT. And nearly 2 years later, his PSA began to rise with a PSA doubling time of about 6 months, conventional imaging negative. So we touched on this a little bit earlier, but this is our non-metastatic castration-resistant prostate cancer patient. So this is seen in a patient whose PSA is rising despite castration levels. One thing to think about here is to always confirm castration level prior to placing in this disease state. Just because they're on Lupron or something like that, it is good to check that testosterone and make sure that it's there. After confirming, I think most of us would order a PSMA PET for this patient. Dr. McKay, do you think advanced imaging is going to change the management or treatment for these patients? I think that's kind of, it's sort of shrinking this disease state a little bit.
Yeah, absolutely. I certainly do. And I think this disease space is ever shrinking because these patients are so high risk for developing metastases that I think you get a PSMA PET and somebody with, NMCRPC on conventional imaging, and a lot of times you find things. So, I think then it opens up the door to, well, what's the role of metastasis-directed therapy for these individuals? Do I treat them like a NMCRPC patient? Do I treat them like a MCRPC patient? So I think there can be some confusion around that.
Yeah, so historically, we'd offer this patient ADT and following with imaging, conventional or PSMA PET, until symptoms or metastasis. But Spartan, Prosper, and RMS showed us that adding medications to ADT led to longer time without metastasis and a longer survival. Now, all these studies use a rapid PSA doubling time and conventional imaging as admission criteria. Given that, do you think all patients in this category, both high and low risk, should get intensification or okay to monitor?
So I think for individuals who have NMCRPC with a rapid PSA doubling time, that's less than 10 months, there's been studies that have been done that their rate of developing metastases over the next year is very high. So I do think that those patients should be escalated. I think the big question is, are they truly, in fact, non-metastatic? And I think if you end up doing PSMA PET imaging and they do have metastases, then I think it changes the calculus around how to intensify their therapy. If they're conventional imaging negative and they're PSMA PET positive, I would still treat them like the historic NMCRPC patient, give them ADT, give them an ARSI with one of the 3 AR blockers, and then consider metastasis-directed therapy as well.
Okay. Studies show that there has been lack of adoption of treatment for this treatment intensification. I'm not sure if this is related to education, financial concerns, or time constraints. How do you think we as APPs can help with this?
So I think it's, the thing about this state is a lot of times it's probably discovered first by the APP because these patients are coming in, they're coming in for their hormone therapy, they're getting their Lupron, they're getting their PSA checked, and you think of them as being on autopilot and they're coming in for their autopilot checks. And then all of a sudden you're like, wait a minute, your PSA is going up and your T is still low. And so, I think that is the trigger to say, maybe you're not going to be the one prescribing the actual medication, but the trigger to say, hey, you know what, let me see, have you gotten a scan in the last year? Sometimes I see patients that come to me and they haven't gotten scanned in 5 years and they've had biochemically recurrent prostate cancer. So, okay, let me tee them up for a scan, and maybe the next time they come in, let's make sure that they see, the provider, maybe they're seeing their urologist or the medical oncologist so that we can make a decision around what's happening to them. But I think most of the time these patients are going to be found in the APP clinics,
Completely agree. That's usually how it happens to working at clinic as well. And then with intensification of treatment, we're, once that gets decided, we're also helping out with coordinating all of the process, getting prior authorizations and getting them on board with any medication that's added for their intensification of treatment.
Great. Our final disease state this evening is metastatic castration-resistant prostate cancer. So this is the same patient. He was started on apalutamide with a good response. However, 18 months later, his PSA begins rising again with similar kinetics. Bone scan reveals new lesions in the pelvis and ribs, but he remains asymptomatic. So he's now castrate resistant. This is defined as disease progression despite ADT with a castration level of T. Now, this patient is much different than a patient that has already received triplet therapy earlier in his disease. So obviously different presentations. So again, what are some important considerations for our initial evaluation of these patients?
I think a lot of times when we're seeing people that are developing MCRPC, a lot of what we decide to do for these individuals depends on what kind of therapy they've received before. And that's exactly how it's broken out in the NCCN guidelines. They literally break it down with if somebody's got MCRPC, have they seen a prior ARSI? Have they seen prior docetaxel? And you're almost developing a grid answering yes, no to those two questions. And then I think here is where it really matters around their genetic testing because we actually do have PARP inhibitor monotherapy and combination therapies for people that have HRR gene alterations. So critically important, like as APPs, you all are seeing these patients in the clinic as they may be developing MCRPC, checking to see have they had their genetic testing done? Have we sent the tissue off? If they don't have tissue, should I get a cell-free DNA test on them? So ensuring that that's ordered and available, and and then assessing are they bone only versus non-bone disease, because that'll kind of also help with considerations around radioligand therapy.
So we have our buckets kind of hormonal therapy, chemotherapy, radiotherapy, PARPs, immunotherapy. As you're kind of evaluating these patients, normally PARP inhibitors were sort of reserved for later in the disease state and based on if they had these genetic mutations. Do you think that as in metastatic hormone sensitive, we're sort of moving things up and combining treatments earlier? Do you think PARP will make an earlier entrance into some of our patients' treatment?
I do think so. Actually, data from the Triton 3 study looked at monotherapy rucaparib versus a physician choice alternate ARSI or docetaxel in people who were docetaxel naive, and in a subgroup analysis comparing rucaparib to docetaxel, actually rucaparib resulted in improved outcomes compared to doci. So I think that study really helped position PARP inhibitors even in the pre-taxane setting for MCRPC. And there's been 3 studies, Magnitude, Propel, and TALAPRO-2, that have looked at ARSI PARP inhibitor combinations in the frontline MCRPC setting. And there are now FDA approvals for each of those combinations in BRCA1/2 mutated patients for NIRA-ABI, and olaparib-ABI, and then HRR alterations for talazoparib and enzalutamide. So I think it's going to be critically important to, make sure that these patients that are seen in the MCRPC setting have had testing. I think one other comment to make, and I don't want to digress this, but I think something that the APPs help a lot with is actually medication reconciliation. And with the ARSIs, there's a lot of drug-drug interactions, particularly with enzalutamide, with the DOACs, with statins, with other very commonly used agents in the clinic, some of the calcium channel blockers. So, I think understanding patients' concurrent meds that they're on for their various comorbidities may help with selecting one agent versus another.
Yeah, I think just to get back to genetic testing, I always wondered kind of when was the right time to order it, because I felt like although I kind of knew which patients should get genetic testing, it didn't seem like it came into play until quite later. But now, with this new data coming out, maybe it's going to be used earlier and earlier. So just another gentle reminder that every metastatic prostate cancer patient should be getting genetic testing. Doris, can you tell us how genetic testing works at your center?
So we actually have implemented genetic testing early on. Now with every new patient that is metastatic or high risk, we try to get genetic testing done within their first follow-up visit or within the first 3 months. And because geneticists are, they're really busy and they were not able to get our patients in within a good amount of time, we started doing this new process where we actually have started consenting patients for genetic testing in the office. So the patient gets to see this video provided by the geneticist, by the genetic team. If they agree with moving forward with genetic testing, we then move forward in consenting them. They get tested in our clinic actually. And then once the results is available in about 3 weeks, that's when they meet with the geneticist to go over the results. implications. That's when the geneticist takes a formal history intake of, of any other prior history of cancer or family history. But this, we've noticed that this actually has expedited the process and allows us to have these results far in advance than otherwise we would have in the past.
Great. And then just switching back to treatment, I just want to touch on lutetium because it seems to be the topic of all my patients bring it up. They want to use it for everything. They think it's going to be the greatest new thing in their cure. But I believe currently lutetium is approved after chemotherapy. Do you guys see this as an earlier treatment option in the future?
I definitely see it as a potentially earlier treatment option. There's several studies looking at lutetium PSMA pre-chemo, a study called PSMA-4 that is actually already, the results have been released in a press release stating that that trial was positive for its primary endpoint. We're eagerly awaiting the data at an upcoming meeting, but I think we're gonna start to see data about PSMA radioligand therapy pre-chemo. And there's also studies that are actually testing its efficacy in the metastatic castration sensitive setting. And in addition to lutetium PSMA, there's other compounds out there, PNT with the SPLASH trial. So I think there's other agents that are going to be out there. And I think something that is critical on the APP side for management of patients who are on radioligand therapy is obviously the cytopenias, but patients who have significant incontinence or have urinary obstruction, those patients don't make great candidates for lutetium, and a lot of times our APPs are helping kind of facilitate, okay, let's get them plugged in to get the nephrostomy tube, then get them in and, set them up for the lutetium. Or if they've got, incontinence, okay, let's get them into the urology clinic, make sure they've got a condom cath that they're wearing all the time. And so they're not having issues leaking during that first week. So there's a lot of kind of little subtleties with lutetium therapy.
Yeah, speaking of with this large and varied toolbox, there are a lot of side effects. I think we have like 2 minutes left. Doris, do you want to touch on any other medications or specific things you're looking out for in terms of drug interactions or side effects specific to
I think Dr. McKay briefly touched upon this, but I think one of the most common things, or the things that we see the most here, I should say, is because we are following these patients on their follow-up visits after they start these new medications. So abiraterone, just so that everybody knows, again, it's given with prednisone, but we do usually have to follow them on a monthly basis for the first 3 months to make sure that they have not developed any potential side effects with hypokalemia, hypertension, hepatotoxicity. And if that is the case, we're usually dose adjusting the medication until their enzymes come down. Then we re-challenge them eventually. If we've dose reduced to 500 and they're still developing any hepatotoxicity on it, we will obviously discontinue the medication. As Dr. McKay said, we are also the primary kind of guard, checking in all those medications, making sure that they're updated. I tell our patients, because they're older, and so I tell them, just bring them in, bring me all the bottles so that I could take a look, so that I could make sure I give it to them as homework. And I think it's just that relationship that we build with our patients. On ADT, sometimes I check their weights, and I'm like, if I see that they're gaining a little weight, I'm like, okay, I'm giving you homework for next time. So next time you're going to come in and you're going to tell me, how much have you done? So, it is a team approach between our physicians and APPs. We are definitely driving the patient's care and taking care of everything that entails to get them to the best outcome.
All right. Time flies when you're having fun, I think. Unless either of you have anything to add, I think we need to wrap it up as we have just a few minutes left for our brief follow-up assessment. Any last minute comments you want to throw in?
This has been wonderful. I just want to commend the AUA for starting this series. I think we really kind of walk hand in foot with our APP colleagues. I think they're critical to providing comprehensive care for patients with advanced prostate cancer. And I think there's a lot that we can actually learn from one another and grow in the multidisciplinary team. So thank you so much for the opportunity.
Yeah, great. Thank you, guys. Thanks again so much for joining us.
Thank you all.
Thank you, everybody.